One of the thing is that maybe we come back that I know that there's different companies and have their different assays. And one of the company, the leading company out there is, taking the tumors and helping you sort of predict whether there's something that is going to go to the lymph node or not the lymph node. Maybe we can use that and maybe we can just use maybe a case that you've experienced and maybe something that worked or something that didn't work, so that maybe we can use that case study to showcase potential, the benefit and possibly the pitfall, like the false positive, false negative, everything you just talked about.
Sure, and the problem is that all these tests have been validated on groups of patients, but they really haven't been compared to each other or really evaluated in the context of how much value they add over existing parameters. And another important thing to consider is, what is our clinical threshold for intervening for a patient? So let me explain what I mean by that.
Sure.
Let's say that we're trying to decide if we should be more aggressive with imaging surveillance for a patient because they might have a higher risk of metastasis or recurrence. And our current parameters say that this patient has a 10% risk of recurrence. Let's say the addition of a gene expression profiling test might be more accurate or might improve that accuracy. And maybe it would show that the patient has a 12% or 13% risk. But is that enough of a change to change my intervention for the patient? So and every physician's going to have, this is going to be different, but we have to think about, what is your clinical threshold for doing something different, either giving a more aggressive plan of treatment or monitoring, or withholding something that might be FDA approved for a patient based on simply a molecular test. And so it's clear that these tests add prognostic value, but it's not clear how much more value they add, and whether really it depends on different clinical scenarios, whether it would change or meet your clinical threshold for changing management for the patient. And so what none of these tests have done yet is shown in a clinical trial that that there's benefit to the patient. So in other words, could you take a group of patients and randomize them to a particular treatment or surveillance based on a genetic expression profile test, and then because you do that, then ask, did those patients benefit? And that's what we don't know. In other words, by being a little bit more precise with the prognostication, we don't know if that's enough to really make a difference or not. Because if it doesn't, then it's not worth the cost. And as I said, there's always the risk of false positive and false negative tests, in which case you might be harming the patient by doing something based on the test result. So I think that the future is bright for these. We always want to try to offer new things for our patients, and we're in the molecular era where we can get so much more information than we used to be able to get from patient tissue. But I think we have to tread carefully and be sure that before we start using the test result for patient management, that we're sure that we're doing it in a way that we know is going to benefit the patient.